This is QD Clinic. Hi, I'm Jack Cush, Executive Editor of Rheum Now. QD Clinic is brought to you by Rheum Now Live, where great rheumatologists like us go to great meetings like this. Go to rheumnow.live to register. Today's case, myeloma with swollen joints. Uh-oh. Yeah, kind of complicated again. 70-year-old African-American male with a history of multiple myeloma, currently under treatment. He's had previously hypercalcemia, neuropathy. He's had arthritis in his hands and knees. And in fact, he shows up with DJD changes in his hands. But now he comes in as referred by the oncologist because of his knee, specifically his left knee more so than his right. But he says both are a problem, and he wants a steroid injection in the left one because he was given that in the past, and it worked pretty well. He does get episodic courses of therapy for his multiple myeloma with Revlimid, Velcade, and Decadron intermittently. He's on Neurontin for his neuropathy. He has some renal insufficiency with a creatinine about 1.8, a chronic anemia, and he has lost a lot of weight with all of this. He previously had carpal tunnel syndrome prior to having the neuropathy. Now he's got a sensory neuropathy. On exam, he's got a big left knee effusion, small right knee effusion, and contractures in his hands, along with DIP, PIP, osteoarthritis. His hematocrit's 33, his SED rate and CRP are, actually SED rate's 12 and low. His CRP is a little elevated at 3.6 milligrams per deciliter. Uric acid's normal. He is seronegative for rheumatoid factor and CCP. On exam, he has 8 tender joints. Both knees are swollen. As I said, the left one greater than the right. His CDI 17. He has no nodules or other skin findings of any kind. He has no history of gout, no history of other disorders. And the question is, what would you do? So when I presented this with a group of rheumatologists recently, most were not interested in further laboratory testing. Most were interested in getting a joint aspirate. So since this was a new finding and he had a big knee effusion without a diagnosis, and that's what we did. We aspirated the joint and got back blood, a bloody effusion. Again, a lot of red cells, not that many white cells, no crystals seen when sent for synovial fluid analysis. X-rays of the knees showed pretty advanced osteoarthritis, and the question is, what else would you do? In this case, we actually did an MRI because we were considering bloody effusion. You're looking at either mechanical derangement, torn intra-articular structures like a cruciate, but more likely, elderly male like this, pigmented villonodular synovitis gives you bloody effusions. Sure enough, on MRI, he did have evidence of iron deposition within the synovium. What you get on a T2 weighted image is because it's iron, it shows up as black, and a fair amount. A lot in the left knee, a little bit in the right knee. So is the right knee also responsible? Well, it's hard to know because usually PVNS, pigmented villonodular synovitis, also called benign tenosynovial giant cell tumor, TGCT in the orthopedic literature. It's usually a monoarticular problem, usually knees. It can often be a nodular swelling over the hand or over a single joint like a PIP. It is a benign synovial or tenosynovial neoplasm. It's very, very slow growing. It doesn't really go anywhere. Some of them may require surgery, mainly because of continued symptoms or the bulkiness of the knee. They can be surgically excised, and recurrence is common. So your orthopedists generally don't want to jump right in and do surgery on these cases. So again, you look for a T2 MR as the diagnostic test, or getting a synovial biopsy. You get, again, no signal or diminished signal in the areas where there is PVNS synovitis that has heavy iron content. If you're looking for a clue, it could be from the bloody synovial fluid tap or from an abnormal MRI. The question is whether or not to surgically excise them. And this orthopedist felt that there wasn't enough there, and he wasn't symptomatically restricted. He wanted us to manage it with aspiration and occasional steroids, and we were going to follow the guy. There is a newly approved, and there's some other therapies out there that have been tried as injectable therapies. There's pexidartinib. Pexidartinib is a new colony stimulating factor 1 receptor targeted therapy that has been shown to be efficacious. Small studies, this is viewed to be an orphan disease. Mixed results in the community since it's been approved. The other options that are out there, aside from surgical excision and this FDA-approved therapy, would be the use of radiation synovectomy or external beam radiation, or very old therapies. I don't think that anyone's doing that anymore. These cases are often best managed by the orthopedist, but if they're not doing surgery, they end up in your office because you're the rheumatologist and you take care of the things that no one else seems to know what to do. Again, congratulations on being a rheumatologist. We'll see you at Rheum Now Live.